Shingles.
Thank you, Sandy. Good afternoon, and wow, what a crowd in this weather. I barely made it across York Avenue, so I'm pretty impressed. The reason I don't use a PowerPoint is the first thing that happens when a PowerPoint turns on is what turns off? The lights. Okay, what happens at 2 o'clock when the lights turn off, right?
Nap
We'll
time.
tend to turn off, right? And so I much prefer to be engaging, interactive with you guys. Of course, using a PowerPoint can always help with some visual aids, but I think that actually my discussion with you guys will hopefully be very, very helpful at allowing us to really understand this condition. Now, somebody had asked me earlier, are you a dermatologist? And I said, no, why would you say so? Oh, because you're speaking about shingles. And yes, shingles, in and of itself, when you just think about it, is a skin rash. So why is a neurologist speaking about shingles? Well, as you may know, and we'll talk about, shingles actually is a neurologic disorder which has a skin manifestation. Okay? So let's start from the beginning. Okay? I'm not going to ask anybody to sort of disclose their personal medical information, but I had chickenpox, and I would assume that most of you in this room, when you were younger, had chickenpox. Chickenpox is caused by a virus called varicella zoster. Now, varicella zoster virus is a very interesting virus. It is in the family of the herpes viruses. Okay? And then many of us hear the word herpes and we think, oh, negative things. I don't have herpes. Well, varicella zoster is a form of a herpes virus. And what that means is it's a virus that has two phases. First phase is some sort of initial infection, which in the case of varicella zoster virus is chickenpox. And many of you have had chickenpox, and interestingly, your grandchildren won't, because there's now a vaccination. So most children will not have chickenpox, although some will fail the vaccine or will have it before 1 year when the vaccination is given. So we still see babies with chickenpox. But chickenpox, of course, is a rash that covers your whole body. It's itchy. You probably all remember taking the baths with the calamine lotion and the oatmeal, trying to get through it. And for most people, especially for children, it's really a nuisance, painful, but then it goes away. But it doesn't really go away, and that's the point. Once you have one of the herpes viruses in your system, it stays in your system for your entire life. Now, the varicella zoster virus is very unique because where it stays is not in your blood cells, it's not in your brain, it's in the nerves, and specifically in what we call the dorsal root ganglia. The dorsal root ganglion is the area right outside the spinal cord, at each level of your spinal cord, where the sensory nerves from your skin enter in. And so, where the shingles virus lives, or the varicella zoster virus lives, is in each and every one of those sensory ganglia in your body. And actually, it's not just along the spinal cord, it's also the nerves that go to your face. And these are nerves for cutaneous sensation. What that means is that these are nerves that let you feel. When you touch your skin, you can feel that. That's the nerve, or the set of nerves that actually are, that contain those dorsal root ganglia. And so, varicella zoster virus hangs out, and it may hang out for the next 80 or 90 or 100 years and do absolutely nothing. But if your immune system starts to wane, or perhaps for no apparent reason, sometimes people who get shingles really don't have a specific cause. Age is the major risk factor. But as you get older and your immune system wanes, and your immune system may forget about the shingles in some regard, so that the immunity wanes, the virus may decide to reactivate. But interestingly, it does not reactivate in the whole body. It reactivates almost always in one of those ganglia that I was speaking about. And because it activates only in one ganglia, it's going to cause a rash that is very much discrete and focused. Okay? So it's not going to be a rash in your whole arm or your whole body. It's going to be a rash usually along a band usually on the chest, the abdomen, the leg, the arm, or even in the face along a segment, upper, middle, or lower. These are all based on the individual sensory nerves that innervate the entire body. And so, I assume some of you are here out of interest to learn, which is wonderful. Lifelong learning is so important. Some of you may be here because you've had shingles or know somebody that had shingles. Okay, and if you've had shingles, you know what I'm talking about. It's not a rash that you wake up with and have everywhere, like a typical viral rash. It's very focused. And sometimes all you have are 2 or 3 or 4 vesicles. And sometimes you have dozens or hundreds of vesicles in that region. The shingles rash itself lasts about 7 to 10 days. So what's the big deal? It goes away. Well, does it really go away? That's the question, right? So for many people it does, and in young people often it does. It's very unpleasant, it itches, it burns, it tingles, it feels funny. Then it goes away in about 7 to 10 days. So again, why is the neurologist here? Well, here's the problem. When you activate the virus along those nerves, you can damage those nerves. And so even though the rash comes, stays, goes, disappears and heals, the nerves may never be the same in that region. And that is really where the neurologist gets involved. When patients have a very unpleasant condition, and you may have seen this on commercials, but I'm not a commercial, called post-herpetic neuralgia. And that is really where patients suffer. Okay? Post-herpetic neuralgia is defined as pain that persists from the shingles for more than a month after the rash resolves. So you're allowed to have pain for a few weeks, but if it's a month later, 2 months later, and you still have that pain, that is called post, after the fact, herpetic, because it's a herpes virus, neuralgia. Neuralgia is a painful neurologic process. Some people confuse post-herpetic neuralgia with another type of neuralgia. Anybody know what trigeminal neuralgia is? Anybody ever hear of that? Okay. They're totally different, but they both have the word neuralgia, so don't confuse them. Post-herpetic neuralgia is caused by viral-induced damage to the nerves. Now, this is an interesting point. Does the brain itself have the ability to perceive pain if it is directly damaged? I guess I'll ask the question a different way. Does the brain have pain receptors? The answer is no. This surprises people. The brain itself does not cause pain. However, the brain perceives pain. Okay? And that's really, really important to remember. In fact, and I know some of you just had lunch, but some of you may know that a neurosurgeon can put somebody to sleep, open up their skull, wake them up, and operate on their brain while they're awake. It doesn't hurt. In fact, they do that often to make sure that they're not damaging the parts of the brain that would cause neurologic dysfunction. Okay, that's really important to remember, because when you damage the nerves, the reason that there's pain is that the nerves are sending an abnormal signal to the brain as if there's a painful stimulus when there is not. And unfortunately, the brain doesn't do a great job sort of saying, well, it's not really there, and so I'm going to ignore it. Okay? We even hear this in people who have amputations. You know, somebody who might have had a military injury and lost an arm. They'll say, it hurts in my left thumb. But you don't have a left thumb, but I can still feel it. It's because the brain has the map for that. And doesn't, even though it's obvious to the person that they don't have that limb, the brain pathways are still there. And so for shingles, it's similar. Even though the rash is gone, and when you look, there's nothing there, the nerves are still sending an abnormal signal to the brain, and the brain perceives that as pain. Now pain, and one thing I can say for sure, is everybody in this room has suffered pain at some point in their life, physical pain, right? You might have stubbed your toe, you might have had appendicitis, you might have had a neurologic injury. Pain comes in different flavors. The most common type of pain is indeed somatic pain. That's the pain that happens when you stub your toe. It hurts in that area. Other types of pain are deeper pain, visceral pain, which comes from organs. But the pain I'm talking about now is the pain that is often the most difficult to deal with, which is neuropathic pain. Pain that comes from damage to structures of the nervous system. The most common causes of neuropathic pain include shingles, which we're talking about today, but I'll also mention that diabetes and a neuropathy from diabetes is the most common cause of neuropathic pain. So how do you know if you're having neuropathic pain? Neuropathic pain feels different. Some of you I saw nodded when I said diabetes, so you may know what I'm talking about. It's the kind of pain that almost is numb, but it hurts at the same time. How could that be? Again, the brain is sort of misperceiving it. So it's a numbness that also hurts, and it's often associated with a burning or a tingling sensation. It can feel cold and hot at the same time. It can feel sharp and dull at the same time. It can come and go. It's often worse at night when you're trying to fall asleep, and then suddenly you feel all the sensations. And it can hurt more just from plain touch. Okay? If anybody's ever had a sunburn, they'll know what I'm talking about. Anybody ever have a sunburn and then just putting your shirt on hurts?
Yeah.
That's called allodynia. Allodynia is defined as having pain from a non-painful stimulus. Well, if you haven't had shingles and you haven't had post-herpetic neuralgia, you may not know what I'm talking about unless I give you that analogy, because that is another symptom that patients have when they have post-herpetic neuralgia. It hurts just to touch the skin. So even in the shower, the water may touch them and it may be searing, even though it's nice, nice warm or cool water. So just to summarize what I've said up to this point in time, the virus that causes chickenpox becomes dormant in the sensory nerves. It may reactivate, leading to shingles. One of the ways that we actually learned how the nerves innervate the body is by looking at hundreds of patients with shingles, because it draws it out like a coloring book, right? And so, for example, at the level of your belly button, that is the thoracic level 10. You don't need to know this, but I'm just giving you an example. At the level, for example, of your upper face, that would be the trigeminal level 1. And so by looking at many patients with shingles, we've sort of determined where the nerves actually innervate, which is sort of interesting. The most common location for shingles is on the chest, and often it will start in the back and come around. It will only be on one side. Okay? And so we actually see patients who will come in, and sometimes the doctor will think, oh, it sounds like you have a herniated disc, because you have pain that's radiating. But I always tell my medical students this: if a patient tells you they have pain in the back or the neck, and it's radiating across or down, you have to actually look. Isn't it funny when you tell a doctor, my leg hurts, they never look at your leg? Did it ever happen to you? It happens to all of us, right? And you say, but it hurts here, why aren't you looking? Oh, because it's arthritis, I can feel it. Look, right? We always tell our medical students, the first thing you do when somebody has pain somewhere is you look at it. You'd be embarrassed if it turns out the reason the patient has pain is because they have a painful rash there, and you told them it's arthritis or a herniated disc, right? So you have to look. And so I would ask you guys to remember that. If you go to a physician and it hurts somewhere, you might want to say, well, do you mind just looking and feeling? You might think it's obvious to the doctor, but in this day and age, we get so little time to spend with patients. We're so distracted by the computers that we have to click and click and click and click and click and click. You've all seen that, okay? But sometimes we forget that there's a person sitting across from us, okay? We don't forget, but sometimes it becomes so distracting that we don't do everything we're supposed to do. And so sometimes you might want to remind your physician, hi, I'm here, take a look. Okay. All right, so let's talk a little bit about shingles, what it feels like, how we treat it, and then we'll talk about how we might prevent it. Okay. The first patient I showed with shingles actually was a young woman. She was in her early 20s. So I don't want you to think, I know that this population skews, you guys are still young, but you're older than 20s, okay, so am I, okay? But so, you might look and say, well, shingles is a disease of older people. Certainly, shingles is more common in older people, but it can happen at any age. In fact, every year we have medical students who develop it, probably from the stress of studying and not sleeping, and they get shingles. But of course, the older you are, the more likely it is that you're going to develop shingles. It will manifest as a painful rash, which I mentioned earlier. And if you have the shingles itself, you should go see your physician. You don't need to see a neurologist for regular old shingles, but you should see your physician. Your physician may want to treat you with an antiviral medication. In fact, I would recommend that they do, because it will kill the virus a little bit faster, okay? And it may prevent the pain that comes later. It's a little controversial as to whether it does or doesn't, but the antiviral medication that we use, called valcyclovir or Valtrex, is so safe that there's really almost no reason not to give it unless you have a contraindication. So obviously your individual physician will determine that. Okay. The rash you will expect will go away, and it will. It will crust over, it'll go away. But if the pain persists, then you need to speak to your physician again, and you want to get on top of this as soon as possible. I am a big believer in the following tenet of neurology, which is that pain begets pain. What do I mean by that? The brain is great at learning, isn't it? You're all learning right now. Okay. Well, unfortunately, the brain can learn bad things too. And if you have an abnormal signal that is sending a pain perception signal to the brain, and that's happening day after day after day, those circuits are being connected and strengthened, and eventually that pain becomes pretty much permanent because the brain develops a memory for that pain. The medical term for that is central sensitization. What that means is that when you have a peripheral pain that lasts long enough and it's neuropathic, your brain is going to develop the memory for that pain. And even when the original problem is gone, that pain is going to stay. This is a problem. And that's why with shingles pain, I like to treat it aggressively and early before the brain has the ability to do that. Now, once the brain has done that, there are still things we can do, but it's a little bit harder. Okay. So how do we treat the pain from shingles? There's a number of ways we can go about it. Of course, medications are helpful, and I'll throw out, you don't need to know all these medications, but I'm going to mention the ones that are the most commonly used, and some of you may be on these medications, frankly, for other reasons. The most famous medication is probably a medicine called gabapentin, also known as Neurontin. Many people are on that. That's a commonly used, very safe medication. I'm not going to go around and ask if you're on gabapentin, but if you are, many of you are probably on 100 or 200 milligrams a day, maybe 300 milligrams a day. If you looked at the studies for the shingles pain, the median dose was 1,800 milligrams a day. And it's safe as long as you build it up. And so what I see, and it's always unfortunate, I'll see a patient who comes in to see me 3 or 4 months into suffering miserably with shingles pain. And they'll tell me, oh, I'm on gabapentin, it's not working. And I'll say, what dose? And they'll say, oh, I'm taking it 3 times a day, it's not working. What dose? Oh, 200 milligrams 3 times a day. Well, that's 1/3 of the dose that's probably going to be effective. It doesn't mean you should start on that high dose, but the point I'm making is, all because a physician is prescribing the correct medication does not necessarily mean they are prescribing the correct dose of that medication, right? And often they're nervous, and they say, well, I don't want to push it, side effects. You have to balance side effects with pain, but that medicine that I just mentioned, the gabapentin, assuming your kidneys are normal or relatively normal, really has no dangerous side effects. It can make you a little sedated, but then you just lower the dose, right? So I think it's reasonable. Now there's a cousin of gabapentin called Lyrica. Some of you may have heard of that. It's much more expensive, not necessarily any better, but some of us like to use that medicine because it can be given twice a day. But it's much more expensive, and your Medicare is going to give you trouble. They're going to put it into your donor hole, and it's going to cost you $800 to fill your prescription. That's never fun. The gabapentin is generic. How do those medications work, by the way? I mean, not that you guys need to know pharmacology, but I think patients like to know how medicines that they're taking work to help them in a general way. Unfortunately, a lot of my own residents and medical students don't know how the medications that they use work. And so one of the things we try to teach them is not just to know that something works, but why it works. Because if you understand why something works, you're more likely to use it correctly and not to give the patient another medication on top of it that actually has more side effects because you're treating the same mechanism. So the way that those medications like gabapentin work and Lyrica is they actually work, and this is interesting because if you remember what I told you earlier about how shingles pain happens, Dr. Gaffey, how are you? Is basically that it reduces the impulse of nerve activity from the nerve I mentioned around the spinal cord to the brain. It reduces it actually by blocking entry of calcium into those neurons, and that is required to connect the nerve in the spinal cord to the nerve in the brain. And so it basically turns down the volume on the nerve innervation to the brain. And that's how it works. It also works, by the way, for diabetic nerve pain and even for seizures at higher doses. So that's one mechanism, and that's fine. And it works pretty well for some patients, maybe 30–40% of pain reduction. Has anybody ever heard of Cymbalta? A lot of you are nodding yes. Cymbalta, also known by its generic name duloxetine, is a newer medicine that is also approved by the FDA for shingles pain. That's where you heard about it. If you haven't taken it, you saw the commercials for it. Right? That's the one with the flowers in the background and the person dancing while they tell you all the side effects. Right. So the reality is that Cymbalta is a very safe medication, but it has to be used at proper doses. It is an antidepressant, and this is a big problem because a lot of patients, if we don't warn them about that. Has this ever happened to anybody? You go to the doctor, they give you a prescription, they say this will help you. You go to the pharmacy, and then you're told it's an antidepressant. And then you go back to your doctor and say, I'm not depressed. Why are you giving me this? So I always warn my patients. This is used for multiple purposes. yes, it is FDA approved as an antidepressant, but it also has FDA approval for the treatment of nerve pain, and, by the way, for the treatment of fibromyalgia, another condition where people have chronic widespread pain that I treat very often. Which actually gets to the interesting sort of uber question of, do we really know what's going on in the brain if we have one medicine that works for 3 conditions that really have nothing in common, but probably have everything in common? This all gets down to brain chemistry. We don't really understand the brain very well. And we use the medicine for one thing, and we see it helps for something else, so then we get it approved. It's not actually designed for that. So what duloxetine or Cymbalta does is it's like many other antidepressants, like sertraline or Zoloft, Paxil or Prozac, right? It raises the levels of serotonin in the brain, but it also does something else that those medicines don't do. It also raises the levels of norepinephrine, which is another chemical. We don't understand why, but for whatever reason, that helps reduce the intensity of pain. Another older medicine from the 1960s or 70s is Elavil, also called amitriptyline. Its cousin was Pamelor. Those medications also work. And those are old medicines, and there's no drug reps coming in with pens and things, but they work really well, and I use them at very low doses. The problem is in older patients, it causes a lot of dry mouth, constipation, and sedation. So you just have to be very careful with the dosing. Okay. But the good news is there are medications that work, and there's really actually, most of my patients with postherpetic neuralgia can do quite well with the appropriate treatment. The problem is, like I said, very often they're underdosed or frankly not treated. Now, not everybody likes taking pills, and not everybody does great by taking pills. I'm going to mention one other option. Has anybody ever used a lidoderm patch, right, a skin patch? So lidoderm, which is a skin patch that contains lidocaine, and I don't work for the companies, I'm just mentioning the product, is actually a skin patch which numbs the skin a little bit. And it's really, I mean, some of you may have been given that skin patch for chronic back pain. Honestly, has anybody found that it really helps so much? It doesn't really help so much. But it helps for this. This is what it's approved for, actually. You put it right on the area where the pain is. And that reduces again, it reduces the nervous system's reaction by sending those signals up to the brain. That's the theme here. It's, when you have postherpetic neuralgia, it's the wiring that gets impacted. And then it's the brain that learns that memory. And so, I'm not here to teach you again how to take care of patients, but I'm just giving you the generalities of how we approach this, okay? But of course, a bigger question that patients have is, how do I prevent getting shingles in the first place? This all sounds so horrible. I don't want this, okay? Now, unfortunately, there's no way to 100% prevent shingles. But the good news is that about, I don't exactly know, 5, 6 years ago, maybe a little longer than that, the FDA did approve a vaccine for shingles. Now, the vaccine for shingles is recommended for all adults over the age of 60, unless you have some sort of contraindication, like, for example, a very, very suppressed immune system. So most patients can get this vaccination. And in fact, recently they just changed the recommendation where even people over 50 can get it. And what does this vaccine do? What this vaccine does, actually, is it gives you the vaccine contains a live virus. It's actually given you chickenpox, except it's giving it to you in a way that the virus is deformed so it can't make you sick. But the immune system gets fooled and still reacts to it. And so what it does is it boosts up the immunity that probably has been waning over the years to remind your immune system that it's already seen this virus, and it allows those antibodies to come back. And this vaccine is effective. It's called Zostavax, and it reduces the rate of shingles by 50%, but not to 0, but by half. I had one patient who was very upset when he got shingles a year after getting the vaccine. He said, but I got the vaccine. It didn't work. I said, well, no, it worked, but unfortunately, you still got shingles. It's a 50% reduction. But so if you were going to have 100 people get shingles, you'll get 50 people who get shingles, like if everybody is vaccinated. But what it also does is it reduces the rate of post-herpetic neuralgia by about 60 or 65%. It has actually a greater reduction for reducing the post-shingles pain than it does actually the shingles itself, which makes us ask an interesting question. If those patients who got the vaccine are still getting shingles, why is it that they're getting a lower rate of the pain after shingles? Probably it's because the shingles they got weren't as bad, weren't as protracted, and they healed more quickly. And so I would, again, I'm not providing individual medical advice, but I would strongly recommend that if anybody in this room has not received the shingles vaccine, that they speak to their physician and find out whether they should. Maybe there's an individual or specific reason why you were told not to, and that's fine, but I would ask. Because this is a way to prevent a disease that, as I mentioned earlier, can be quite painful. Okay? So that's called the Safdieh, and it is a shingles vaccination. Of course, we don't necessarily know what's going to happen with all those kids who got the vaccine against chickenpox and never got chickenpox. Are they going to need the shingles vaccine? Probably they will, because it's the same idea. The immunity will wane, and then they'll need it to come back. So at this point, we've talked about what the virus is. We've talked about how it affects the nervous system. We've talked about some of the common treatments for it, and we've talked about the prevention of shingles. We also talked a little bit about how the brain perceives pain and how actually the connections between the peripheral nervous system and the brain that lead to pain, when they're left unchecked, they lead to chronic pain, and that's called, again, central sensitization. Okay. And so I hope that that overview was somewhat helpful. Okay. I'm trying not to overload you guys with too much information. Okay. But I do want to take a few more minutes and just talk about some of the slight amount of the research that's happening going forward into the future. There was recently a study that just came out, which really surprised a lot of neurologists, and may surprise some of you, that patients who have post-herpetic neuralgia, if you check their saliva, they actually are still shedding the active virus. And so it may actually be that the reason that people after shingles still have pain is that they still have shingles, and that the virus is still there at a low level, but the rash is gone. Now that's somewhat controversial, but it has now led to a study which is ongoing in the Western United States. They're looking at this as to whether actually treating somebody with an intravenous antiviral medication when they have shingles might actually help. So in some of my patients who have shingles, if they're really in pain and they're not responding to the medications I'm giving them, and they're not getting better, and it's been 6 months, and it's really not fun as the patient or frankly the physician, because you want to help the patient wants to feel better. Sometimes I'll do that. I'll say, well, let's just try antiviral medication just to see if that might help. And I've had mixed success with that, but I'm just mentioning that as a side note. There are always advances that are occurring. Okay. I was told that people really want to ask questions. That's what I was told. So I'm happy to keep going and talk a little bit more, but I'm also happy really to open the floor and make this an interactive discussion, because often by somebody asking a general question, it allows me to make some other teaching points that might be relevant to everybody. And it looks like there's a lot of hands, so I think I'm actually, Sandy, if it's okay with you, going to open the floor.
No, I think that's a great idea. Thank you,
Okay,
Dr. Singh.
great. So do you want to help manage the